Hello everyone. Assalamu alaikum wa rahmatullah. Today, inshallah, we will have this free session for part 3 introduction. And it's very special today because we will meet the new members, your colleagues who just passed their exam in May. So we can discuss with them what about their thoughts before the exam and what about this time, how did they manage the time, and what about their studying at this time, and final advice from them to you, just to put you on the track, because it's your turn now to make it real. It's a dream, and this MRCOG, it's a very prestigious possession and certificate. So we, all of us, aim to have this certificate. Some of us already had it, and it's now your role to make your dream uh, like true. Okay, so we will start with our candidates at the start before the introduction. We have Dr. Vanita here. Hi, Vanita.
Hello, ma'am. How are you?
I'm doing well. How are you after your success?
Oh, it is a very great feeling. Such a challenging exam, but yes, with your help, we could do it.
Yeah, exactly. So I will leave the mic with you now. Okay, I will mute myself. And now it's your rule just to give advice and tell your colleagues about how did you prepare for the exam, and what about how you um, overcame your anxiety and all the feelings. It's all normal feelings, but it may affect your performance in the exam. How did you do that, and your thoughts before the exam, and give them your final advice after that. Okay.
Yes, ma'am.
Okay, I will mute myself.
Hi, I'm Dr. Pereira. I had taken my exams recently, and my advice would be main is this exams you require daily practice. It is not last minute. You cannot do it last minute like part one, even part two to some extent, because you cannot mug up. So every day you're supposed to practice the stations. Dr. Rana's course is really beneficial because it has to be concise, because not only knowledge, you have to be within 10 minutes, you have to try to complete everything what is needed for that station. So for that, you have to know what is needed. You have to clear your concepts. Without clearing your concepts and just by hearting won't help. Trust me, over there you go blank. But if you, because it's not the same station that will come, it will come twisted and something similar. So you have to understand what the patient needs. You have to put yourself in front of the role player, like she's your real patient and what she wants. Because if you by heart, they get to know what you have just mugged up everything and just vomiting, like verbal diarrhea, that won't work. Am I clear? Am I making sense so far?
Yes,
Okay.
yes, you do.
Is what they see for, to see if you are in your natural way, you are speaking to a patient, consider that, because that is what NHS is all about. I am working in NHS and I do attend even interviews, what they take, and finally how we select is we know how natural that candidate is, that she is not just by hearted everything and come. So Dr. Rana makes one point very clear. She makes you understand the concept, because if the station comes a bit twisted, because you will not get the same, but you will get similar stations. Like for my exams it was on the last day, there were 3 new stations, but I was not lost because I knew something about everything. That is what is needed in this thing. They want to see that you are a safe doctor, you are compassionate doctor, your communication is good, and you are addressing the patient's consent. They don't want to test your knowledge because that is already tested in part 2. But yes, you have to have some amount of knowledge to address the patient, because you can't just tell anything without knowing what it is. Okay. So what I might say is that consistency is very important, and just knowing about the gist of the topic, knowing what is really needed, because in some topics you should make a note to mention what is required. That is what is given in very nice bullet form Dr. Rana has done. Don't talk too much, don't talk too little. Okay, but talk to the point. Anxiety, yes, this you can overcome by going on presenting the cases. So how I overcome I was a very anxious, sometimes I used to go even blank. So everybody will have it. Nobody is brilliant here to face this exam. Even part 2 you can face because you're not seeing anybody here. Like you're having your role player, you're having the examiner. Sometimes there's a lay examiner, so you might get nervous. Give mocks. Mocks exams has really helped me. I have taken 3 mocks with Dr. Rana. Even she was asking why you need it. I said no. I just want to get over it. So I don't feel that that exam is a new place I'm facing, which happened to me. Like I was just feeling I was giving another mock over there and I could get over it. Yeah. This is what I would say. Just consistency, make a study buddy, keep your time, see that you're presenting every day some cases. Okay, take all the mocks, whatever is there. How many mocks you take, it's better for you because you will able to face the real exam. Because finally the real exam is not like just speaking. You will get to know when you take your mocks and you will understand it. Okay. Thank you, Dr. Rana, for helping me in this exam. Really, it is a very nice feeling after finishing part 3. You feel you have done something, but if I could do it, I'm sure all of you can do it. Yeah.
Thank you so much, Dr. Vanita. Thank you, my dear. You covered many points. So many thanks is not enough for your effort to attend us today. I know you are very busy in your work. So thank you so much, my dear.
Dr. Rana, anything for you. Thank you so much.
You're welcome,
All
my
the
dear.
best, guys. I'm sure if I can do it, you all will do it. All the best.
Thank you, Dr. Vanita. Thank you so much, my dear. I think we have here all the points Dr. Vanita mentioned. I will highlight it in the introduction, but one important point she mentioned, I want to highlight now, that just follow the patient agenda, address the patient's concerns, and also just be a safe doctor. Mention the management plan in steps, mention everything, but not talk too much. Don't give the patients like a lecture. And as Dr. Vanita mentioned, your knowledge already assessed in part 2. So here, yes, there is part for the knowledge, but take care that it's 2 marks for the knowledge, 2 marks for the safety, 2 marks for the communication. And information gathering also 2 marks, which usually most of you will consume time in information gathering. So during preparation, make it your target just to have the time management, and also just to highlight the most important points in the management plan, so you will work smart, not work hard. And I will highlight this in my presentation. But now we will have Dr. Nemat. I think she joined. Thank you one more time, Dr. Vanita. Thank you.
Thank you so much.
Assalamu alaikum, Dr. Rana.
Alaikum assalam. How are you, my dear?
I'm fine, thank you.
What about your feelings now? And did you celebrate and enjoy your success?
Yes, actually, I am in my country now celebrating.
Yeah, that's good. Yeah, I know that you traveled to celebrate with your family.
Yes, I did.
Okay, that's good. So I will mute myself now, as I did with Vanita. So just to speak to your colleagues, tell them about everything in your preparation. What about the most important points? And also, what about the time management, your thoughts before the exam and even after? And how did you manage during the stations in the exam? How you managed counseling the patient and everything, okay?
Okay.
I will leave the mic with
Thank
you.
you. Okay, thank you, Dr. Rana. Thank you. Hello, guys. And I wish you all the best, really. Let me just start by saying that this exam, it's not what you know. It's not your knowledge only. It is how you dissipate, how you give the knowledge in chunks, and how the system, there's a system to it, how you let the patient, how they let the examiner know that you know what they're asking you. So just like Dr. Rana put us through, it's many people, all of us, we know all these things, but now the system is how to now bring it out. It's in a systematic manner. Let me give you an example. For me personally, what I really, really appreciated, my previous exams, I wrote this exam before, twice, and my my deficiency was always in patient safety and applied clinical knowledge. Now, it's not as if you don't know concerning the applied clinical knowledge, but how do you say it? For example, you tell the patient that has bacterial vaginosis, for example, you know the treatments, you know what to give the patient, but regarding the patient safety, you have to highlight that if the patient is taking metronidazole, you will let her know first the side effects she's likely to see, she's likely to get while taking it, and then if she now you have to let her know that she cannot take alcohol with it. So that is both applied clinical knowledge as well as patient safety. Same thing with the condom, the what do you call it? Pessaries, clotrimazole pessaries that she has to use. You let her know that it can affect. She can have some irritation, side effects, as well as the safety that she cannot use it with condom. So that is the best thing that I appreciated with Dr. Rana. As she lets you know, as you're telling the patient, you're giving the patient a drug, as a default setting, automatically just say the side effects of the drugs. As you're telling the patient, okay, we want to do this surgery for you, also reflexly, you should also tell the patient the complications of the procedure. So those are the fine points regarding patient safety and applied clinical knowledge. So in my preparation, like I said, she let me know that things have to be systematic. Once you are systematic, it's highly unlikely that you miss a step. But the thing is, it's not something you will cram. You have to apply the systematic steps to each condition for the patient. So what you do for a patient with heavy menstrual bleeding will be different, slightly different from a patient with maybe fibroid or like bacterial vaginosis, but the steps should be there. So that's what I appreciated so much about Dr. Rana. And honestly, she's one of the best mentors I have come across. She's very patient, hardly gets irritated. I don't think I ever saw her irritated, even with the stupidest of questions that we candidates would ask her. You know, she would answer one question, another candidate will ask the same question. She would be patient and answer the same thing. Another candidate can ask the same question again, but she never gets irritated. She never gets upset. That is another brilliant quality of Dr. Rana. And like I said, it is a very passable exam. Let's just be systematic. And by God's grace, I know with her guidance and with hard work from your side, it can be done. So let's just be systematic with it. Consistency is also the key. And inshallah, it will be a success story just like us. It's a wonderful feeling to pass. I can tell you that it's a very, very good feeling. You feel a huge weight lifted off you. And for the first few days, you don't know what to do with yourself, but with time, you get to have your direction. So I wish you guys all the best. I can assure you are in the best of hands with Dr. Rana. Just be consistent. All her study material is what she needs. So I wish you all the best, Dr. Rana. Thank you so much. Thank you so much. When I first met you, I told you my heart story, my heart's desire, my story. And you were sympathetic, you were empathetic, you guided me. And alhamdulillah, it's a success story now. So may Allah guide you. May Allah reward you in so many ways that you never envisage. So guys, I wish you all the best, guys. And thank you so much, Dr. Rana.
Thank you so much for you, Dr. Namat. You are a very hard worker. Dr. Namat was one of the best candidates in the course. So she's a very hard worker. She's keen to study. She's keen to know everything. So it's thank you from my side to you, because you were a very good candidate, actually, Namat, you know. And thank you for your words, and thank you for the advice for your colleagues. And I agree, I totally agree with Dr. Namat regarding what she mentioned. And I remember on the day of the exam, she told me, I feel myself different in the exam, because this point especially, usually, you know, I'm putting more pressure on that in the course. Just when you will mention any medication, give the side effects, any surgery, give the complications, from the start, from session number 1 to session, the last session in the course. So she told me, I feel myself this time different, because I'm now a safe doctor, and alhamdulillah, she passed in this attempt. So thank you, Dr. Namat. Thank you so much. Thank you for making me proud of all of you guys, even the candidates who wasn't able to attend today because of their work. Thank you for all of you.
Thank you so much, Dr. Anna. Thank you. May Allah bless you. Thank you.
To Dr. Namat, thank you so much. Okay, guys, so let's start the introduction. The introduction will highlight also what mentioned by Dr. Namat and Dr. Vanita. Okay, so this part 3 exam, it's not that much hard, but we have to know how to tackle the exam, how to know the tips for the exam, how to know what's needed from you. It's very important that you will tell what the examiner needs to hear from you. This is the tip, or the golden tip of this exam. So let's start. I love this picture. Usually I'm putting this by the end of the course or by the beginning of the course, because it's like a race. And even while at the start of your preparation, you are almost by the end of the race. Okay, so do your best. If you will follow any race like this, you will find the runner will do more effort by the end, just to be the first or to be a winner. Okay, so imagine that you are now in race, and you have to do your best. You have to work hard and smart together to get the benefit from the study with the least effort, and to get the success, inshallah. My first step, and also it's a golden tip, and usually I'm asking all my candidates, do you have a study partner or not? Study partner, it's like the cornerstone of this exam. Okay, guys, it's not like you will study by yourself. It's not like part 1 or part 2, you will handle the book or PDF in front of you, and you will study by yourself. Okay, so here, study partner, this is the cornerstone. Number 1, you have to search, before you are searching for a course or how you will study, search for a study partner. And especially if you have a study partner in your work or in your country, so it will be better, because you will have a same language, same time zone, and you can manage together the time. So study partner, very important, because every day, my advice, guys, to have at the start of your preparation, like now we are in June and the exam in November. So like for 2 months now, you can study like 2 hours daily, and 2 months before the exam, you have to study at least 4 hours with your study partner before the exam, at least 4 hours daily. So you have, and even my advice, 1 month before the exam, you have to do 1 day recall daily with your study partner, like to have 7 stations for you, 7 stations for your study partner. So daily you are discussing together 14 stations, and then you will have your rule by yourself to revise wherever you want. But study partner, this is step number 1. What we will start, what we will end with is the study partner. Okay, so this is first step. Tip number 2, work smart. What about the difference between work smarter or work harder? So if you will work hard, this is a good thing, but sometimes you will pay more effort and you will pay more time, and with what you will get will be less. So how are we gonna work smart here? We have to follow a template. And I will discuss with you today general template for all the modules. But in every module, we have another template. But I will tell you, you can use the general one and make little changes for every module. Okay, guys? And we will discuss this now. So how this will save your effort. If you will follow the template, now you are following the questions in the information gathering, question by question, so you will save your time. At this time, you will be able to finish information gathering in 4 minutes, not more than 4 minutes. And then 1 minute for the explanation, and then 5 minutes for the applied clinical knowledge and ending of the station just to finish your station. So if you follow a template, at this time you will work smart. Put the management plan, highlight, and I will give you now one example why we are discussing the template, how we can apply the template for different stations, and how we can just highlight the management plan in points and not to forget or not to ignore any point. So work smart and don't work hard. You will work hard, but you need to work smarter first. You got my point? So no one of you will understand that Dr. Rana said, don't work hard. No, you need to work a little bit hard, but more smarter, okay? I love this picture also, work smart. If you will see, it's the same mass here for the sphere and for the cube. But in your mind, who will win this race if it's a race? Who can move this block, like, for example, for 10 meters? So for sure, the sphere, because this guy, he's working now smart. He takes the same mass, but put it in a different shape, so it will be easy for him to move. It's the same. Take the exam, make your own thoughts and your own template and your ideas about the exam and apply it, so it will be very easy. With less effort, you will pass the exam. You got my point? Okay.
Yes.
Okay.
Yeah, thank you, Dr. Hosniara. Okay, my third step is time management. So what about the time management, guys? We have 2 points here to comment. Time management, usually you will think about the station, just the station. Yes, it is, but we have general time management. How, as I told you, now we are at the start, you can study with your study partners for 2 hours daily. Okay, take module wise. So we will have the module for example, 1 week or less, okay, for the module. So we can finish in 12 weeks. And after that, we will start the recalls. This is a time management. If you have shortage of time, so you can do 2 modules weekly. So you will finish in 6 weeks, which is 1 month and a half, and then start to do the recall, start to revise. This is the general time management. Try to have one thing to do daily, like Dr. Vanita mentioned. For me, I'm usually at the beginning of the preparation, I'm advising my candidates just to do 1 patient information leaflet daily. Not one, it means just one, I mean 1 case. For example, we will discuss early pregnancy. So now I will discuss today, or I will study today, ectopic. So I have to cover the ectopic, and I love the patient information leaflets, because if you will go back to the guidelines or TOG, it will be like a mess. Just if you want 1 point in the management, yes, you can go to the guideline and just follow the patient information leaflets, even if you have the material. But my advice, just to read it, because you need to know the layman language. It's very important how to counsel the patient. And by the end of the patient information leaflet, especially those of the RCOG or from the RCOG, you will find questions. So usually it's a role player question. Okay, so it's very important to follow the patient information leaflets, and I will show you by the end of the presentation today. Number 2, station time management. 10 minutes, guys, please, in your preparation, starting from day 1, put a timer in front of you. Usually I'm giving time while in the course, I'm giving more than 10 minutes at the start, but I'm telling my candidates after that, I will be strict and I will be adherent to the 10 minutes. Why? Because in the exam, in the face-to-face, because now there will not be online, only for few exceptions. So when the bell is ringing, now you have to move out of the cubicle and to go to the second or next station. So they will not give you 1 second more than the 10 minutes. For the online, you will find the screen, suddenly you will not find anyone in front of you. And all the guys who attended before online exam, they will know what I mean. So no 1 second more. So we need from the start just to manage the time management, okay? So how are we gonna manage it? By putting the timer in front of us, if you are studying with your study partner, put the timer, and every one of you will be the role player for the other and the examiner. And another advice, guys, with the studying with the study partner, I'm telling usually my candidate that if you can pick the mistakes, now you will pass the exam. Once you are picking the mistakes for your partner, so now you missed this point, 1, 2, 3, 4. This will be a great help for you. So in the exam, you will do it and you will not forget anything, and you will not do these mistakes. Even it's your partner's mistake, but you will avoid. Okay? So coming back to the time management, it's very important to have general time management. And this is regarding daily study, and also for the station to be adherent to the 10 minutes. At the start, you can give yourself more time, but by the end of the preparation, like 2 months before the exam, you have to follow or to be adherent to the 10 minutes. So the three tips, one more time. Sorry, guys. Time management, work smart, and study partner. 3 golden tips for this exam. Okay? Coming to the exam itself, what about the format of the exam and everything? So regarding the format, it's 14 stations. I think all of you know that, but I will just highlight this point. You have 2 minutes reading time and 10 minutes to finish your task. This line for the online exam before the recent update from the RCOG, because we have like 30 seconds between one station and another, but you don't have anything in front of you. It's not like you can read the station, nothing in front of you. Just it's like transitional time from one station to another. What about the exam? 5 simulated patient tasks, 5 tasks, 5 structured discussion, and 4 simulated patient tasks with the lay examiner. And because of the stress of the exam, sometimes you will go for the structured discussion dealing as its simulated patient task. So my advice also, if you will find one person inside the cubicle, so this is the examiner, it's a structured discussion. 2 people, so it's simulated patient task. 3 people, so it's simulated patient task with the lay examiner, and take care, this is the highest mark. Why? Because now the examiner will give you marks. Usually the examiner will assess you in 4 domains times 2, so it will be 8 marks, and the lay examiner will assess you in 3 domains times 2 marks, so it's 6 marks. So this station will be out of 14 marks. So pay attention when you will find 3 people inside the cubicle. Please put your effort, make more effort to get as much as you can. And sometimes one of the modules will be here, not sometimes, usually you will find overlapping, but it will not affect each other. So the lay examiner cannot affect the decision of the examiner, and it's vice versa. Okay, so the examiner cannot affect the lay examiner decision. So it's very important, guys, with the lay examiner, pay more attention to these tasks, please. Okay. For the modules, we have 14 modules, but actually during preparation, you will find overlapping between some of these modules. For example, management of labor and delivery, there is overlapping here. You will find antenatal care, maternal medicine overlapped also, and surgery, post-operative overlapping. So usually in the preparation, you can count all these like 12 modules, okay? So or if you want to make it like this 14, but if you will study or during your study, you will find some cases in the antenatal, you don't know it's antenatal or it's maternal medicine, because usually in the antenatal you will find, for example, patient with sickle cell disease, and she's here for her antenatal care. You will find for the antenatal, the pure antenatal, for example, patient with Down syndrome screening, patient with anomaly scan, patient with echogenic bowel. So all these pure antenatal, but usually during our study or during even in the course, I'm making overlapping. So I'm giving the 2 modules together, but I'm giving all the stations. So we have many sessions for these 2 modules, especially because antenatal care and maternal medicine, it's now 28 stations came before in the exam. So we have to cover 28 stations here in these 2 modules. So it's not only 2 sessions, no, it's more than that. For the domains, 2 marks each. This slide, actually, I'm keeping this slide in all my presentations, in all modules. Why? Just to remind my candidates, take care. If you will pay like 6 or 7 minutes here, 6 to 7 minutes, it's by the end 2 marks. The examiner will not say, yeah, this candidate is very good in the information gathering, I will give him 3 or 4. No, it's only 2. So if you will pay more time here, this for sure will affect the patient's safety, applied clinical knowledge, because you will not be able to finish your station. So take care. It's all the domains, 2 marks each. We have 5 domains: information gathering, which is the history taking, communication with the patient and relatives, and I will tell you how to get the good mark here, patient safety points, and communication with the colleagues, applied clinical knowledge. My lovely domain here, I love it really, this domain. Why? Because it's only one sentence. Usually I'm telling my candidates, my pet sentence: your management will be with a group of expert team. This will include, and then put wherever you want, as much as you can, subspecialties. Okay? Like my consultant, a specialized nurse, a specialized midwife. For example, this patient with the spina bifida, I will give you a clear example. So we can involve the consultant, the nurse, the midwife, exercise expert, her nerve doctor, blood doctor for the low molecular weight heparin, dietitian if there is any increase in weight. Okay, so we can, and also we can involve the baby's doctor at this time, just to counsel the patient regarding if the baby will be affected or not, if the patient has anomaly scan with you. So this is the communication with the colleagues. You will tell only one sentence and you will get the 2 marks, and very well done. My advice, just in the exam, sometimes you will not be able, or because of the stress of the exam, you will enter the cubicle and you don't know what about the domains you will be assessed in. So my advice, usually at the beginning of counseling the patient, you will say, now coming to your concern, and then discuss the concern, and then now coming to your management. I'd like to reassure you that your management will be with a group of expert team. This will include 1, 2, 3, 4, 5, and put whatever you want. If there is no communication with the colleagues, this will make your marks here better. It will enhance the marks here. Why? Because now you are a safe doctor. You are involving many subspecialties with you. And usually I'm telling that here in UK, it's different, like different from the Arabic countries, or Egypt or Pakistan or India. Why? Because usually here, I can manage the patient with DVT, but it's not my job. I will liaise with the blood doctor, with the hematologist, to come and see the patient and to prescribe the dose for her. This is what is the practice here in UK, guys. So we have to be aware of that. The problem that most of us, or most of the candidates, are not working in UK, so they are not familiar with the system. And just we are highlighting this point. Take care. No one will manage the patient by himself. No, you cannot manage by yourself. You have to involve other subspecialties. So even if there is no communication with the colleagues, please just to put subspecialties, so you will get more marks in the applied clinical knowledge and patient safety. You are involving a lot of subspecialties with you, and this is what happened here. Okay, so usually even it's like a joke from my husband. He's telling me, do you know how to manage this case? I said yes. He said, so why the OB-GYN usually requesting to come and see the patient? Why you are studying all this and you are not applying in the hospital? I said, because they have to be a safe doctor. It's like medical legality points. They have to involve many subspecialties. Okay, so it's like this here in UK. Communication with the patient and the relatives, just to be listen to the patient. Don't interrupt the patient. Breaking bad news, and be kind to the patient and listen to her. Okay, asking, am I clear so far? Every now and then. This is a big mistake, guys. This is one of the common mistakes in many candidates, not one. You are not asking the patient. You want to tell the management quickly. No, please just take a breath. Am I clear so far? Are you following me? Do you want to ask about anything? This is patient communication. Okay, it's not one thing, but it's many things while you are counseling the patient. Okay, patient safety points. Usually it will be for the correct diagnosis, good explanation, appropriate management plan, some patient safety points like cervical screening in the gynae cases, blood group transfusion concerns in the obstetric cases. I will show you in the template now. So many points in the patient safety. One point very important to explain the medication or explain the surgery. Usually I'm telling the candidates, even me as a doctor, if I will receive one medication and I have a side effect, I will stop the medication immediately. So if you are counseling the patient in a good way, you are telling the side effects and everything, the patient will continue and she will be adherent to her medication. Applied clinical knowledge, this is what we'll need just to revise, just to highlight the points 1, 2, 3, 4, and to go systematically. Okay, as Dr. Namat mentioned, sometimes I find, for example, management of VIN. Start with the surgery, then the medication, then the laser. No, please go with a systematic way. Number 1, conservative. Number 2, medical. Number 3, laser and phototherapy. Number 4, surgery. Even if the surgery, it's the only suitable option for the patient. So say we have conservative and I'm so sorry, it's not suitable in your condition. We have the medical, which is the cream, but this cream has side effects 1, 2, 3, 4. The laser has side effects 1, 2, 3, 4. Surgery, explain the surgery and mention the complications. So this is how you're gonna go systematic in the applied clinical knowledge. And this is the smart way, guys. By the end, if you will start to revise, it will be very easy for you. So these are the domains. We will come again and touch again these points in the template. In any station, this is the general template. You have to do the introduction, setting the agenda, then start to gather the information, then examination of the patient. And here I'm telling now all the candidates, I will not stop on the examination because now we have two opinions. It's important or not important. So it's up to you if you want to examine the patient or not. But from my side, because the examination, it's one vital point in the management of the patient. I will not be able to prescribe or take a decision in any patient without examination. And it's only one line. I'd like to offer you examination in presence of chaperone after your permission. This is in the face-to-face. Okay? Then explanation of the condition, and some candidates forget this point. Take care of that explanation, very important. This is patient communication for the patient to understand her condition. Once she understands the condition, she will be able to choose the option. She will be adherent to the medication, or she will agree for a surgery, for example. Set the appropriate plan, and then ending the station by giving patient information leaflet, another appointment, essential referral, writing back to the GP, or to admit the patient if the patient will need admission. So this is the steps in any station we have to follow. At the start, you will struggle. Open the template in front of you. After that, you will memorize it by heart. So in the exam, you will not feel yourself under pressure. Oh my God, I forgot what I have to say after that. No, you will go fluently. You will go smoothly between one point and another. For the introduction, we are setting one introduction in all cases. And usually my advice, if you want to follow my introduction, I'm more than happy. If you want to make your own one, this will be perfect, because you have to use one paragraph or one sentence or one question you are familiar with. So for example, hello, I'm Dr. Rana, one of the doctors in the clinic today. Can I confirm your name and age, please? And then ask the patient, how would you like me to call you? How can I call you? How can I address you? Or is it okay to call you any name, Julie, for example? So my best question is this one, because this is the most polite question. If you feel it's like complicated, a little bit complicated, so make it easy for yourself. How can I call you? Okay, so very important paragraph, the introduction, and take care where you are. I'm in the gynae clinic, I'm in the early pregnancy assessment unit, I'm in the emergency department. If you are in the clinic, but because of the stress of the exam, you cannot remember where are you, say, I'm one of the doctors in the clinic today. make it like open like this. I'm in the clinic here. It's subfertility, gynae, urogynae, not important. Because if you will mention another clinic now, no, now this will affect your marks. Okay? Because you don't have like situation awareness. Where are you? This is the first point in the situation awareness. Okay? So take care of that, guys, and very easy introduction. And it will make like melting of the ice at the start between you and the role player. Then setting the agenda, and usually also in the template, you can tell whatever you want or just use my paragraph or sentence. I have gone through your notes, or I see your notes, or I have your notes here with me. So whatever you want. And I understand that you are here today because, and then tell the aim of this visit. Very important, guys. You have a problem like anything, or do you want to discuss the results of your blood test or your scan, whatever you have in front of you. Sometimes it will be together. For example, in the ectopic, so you have bleeding and you want to discuss your blood test results and scan results. Am I correct? Yes, doctor. So ask the patient, what about your concerns and expectations from this consultation today? Very important, guys. Follow the patient agenda. Just let her to express her concerns. And usually I'm giving this example in the early pregnancy as well. Patient, for example, with bleeding, okay? And you will counsel the patient from the start about bleeding. And then by the end, she will say, I want to terminate this pregnancy. So where is the mistake here? You didn't ask from the start. What about your concerns and the expectations from this consultation today? Okay? Or do you want to discuss anything else? Do you have any other concerns? Make it easy as much as you can. If you feel it's a little bit complicated, then tell the patient, okay, I will address all your concerns within few minutes. But before that, I'd like to ask you a few questions to know more about you. Or if you want to make it another sentence, like, because this is the first time I see you or I meet you, so I want to ask you a few questions to know more about you. Is it okay? Or do you allow me? Yes, doctor. Then now you are ready to start the information gathering. Information gathering, this is a smart template we need to use. Start with open question. Please, guys, don't start with closed question. Open question is better from English side, and also because the patient will answer around 4 to 5 questions from the open question. So we will start with the history of the present illness, and we will start with open question. For the history of the present illness, guys, we will ask about the problem itself. That's why I'm not putting here questions. For every module, you will find the questions here. So for example, if we are in the early pregnancy, I will be added into the early pregnancy and patient with bleeding. So now my main concern or my main problem here is the bleeding. So I will analyze more about the bleeding. I will ask the patient when it started, what increase, she has pain with that or not, is there any blood clots or not? And I will ask her about things related to the early pregnancy, like vomiting, nausea, which is sickness or throw up with the layman language. Ask about the pain, feeling unwell, dizziness, shoulder tip pain, very important in the early pregnancy, and bleeding, because you have to exclude ectopic. You will not exclude by this question, but you have to ask. You have to ask also about if this patient started the folic acid or not, but don't ask if you know that this patient is a molar pregnancy or ectopic pregnancy, so don't ask this question. But if it's just threatened miscarriage, like patient with bleeding, with IUD, or patient with bleeding and X-ray, you know, these two famous stations, so we need to ask, did you start or have you started your the folic acid? Okay, so this is just one example. So start with open question. How are we going to apply this? Tell me more about your problem. So the patient will start to say, oh, doctor, I have this bleeding 2 days now. There is no pain with that. And it's not that much bleeding. It's just spotting. But I don't know what happened. I'm really worried about that. So now the patient answered that she has the bleeding, started 2 days, no pain. Okay, and she's worried about the bleeding. So this is her main concern now. Okay, so this is how you're gonna apply the template in the information gathering. Regarding one point, we will continue. Okay, this is the history of the present illness. Start with open question, guys. Some of the candidates will start with, for example, tell me when was your last period? This is a very closed question in the menstrual. You have to ask here, you can ask in the early pregnancy, menstrual, in the history of the present illness, but start with open question, please, okay? And then if you want to ask about last menstrual period and is it regular or not, it's okay. I'm totally agree with you. Then personal. Usually in all presentations, you will find 3 slides for the information gathering. First slide for the history of the present illness, and usually in the modules, as I told you, you will find all the questions down here. And the second slide like this, and the third slide like this. So by the end, you will be familiar. You will ask questions fluently because you have, it's the same, but I can put one question, erase or remove one question. It will depend on the situation. So here, after the history of the present illness, you can ask about the menstrual. What about the last menstrual period? Regularity, any pain with period? What about the obstetric? Have you ever been pregnant before? How many children? What about the mode of delivery? What about your recovery at this time? If it's important in some gynae cases, we can ask about discharge from down below. For the personal here, it's smoking, alcohol, recreational drugs, and BMI. And also another advice here, guys, in the history, don't ask double or triple questions. It's really annoying manner for the role player. Because if you will ask the patient, do you smoke or drink alcohol? So if she will say yes, yes for what? Smoking or drinking alcohol. She may be smoker, but she's not an alcoholic drinker. Okay, so you have to ask question by question. Do you smoke? No, doctor. Do you drink alcohol? No, doctor. Pardon me in question. Do you use any recreational drugs? No. BMI, you can ask about the weight to height ratio. Don't use the BMI because it's medical jargon. And usually you will find with the red arrow, when you will find the red arrow, so it's important points. In the obstetric cases, RH, the blood group, and concerns regarding transfusion, very important. And it's one of the patient safety. Any patient will go for surgery. Blood transfusion concerns, very important, okay? To exclude any or to rule out if this patient Jehovah's Witness or not. Cervical screening, one of the patient safety, especially in the gynae cases. Drug allergy, patient safety in all cases. Please don't forget drug allergy. Here, it will be first question. If you will go to the emergency department, for example, or this is the first time you will go to the GP, you have to fill application. You have first question, drug allergy. First question in the emergency, okay, will be, do you have any drug allergy? And you will have like a special color code because if you have any drug allergy, so they will give you like color code red. So all the workers in the hospital, from nurse, midwife, doctors, technicians, anyone will know this person has drug allergy. So it's very important here in UK. So drug allergy, very important patient safety points, guys. Then to complete the information gathering, medical, surgical, usually we're taking this less than 1 minute, okay? So are you on any regular medications? Do you have any medical problems of concern? Do you have any surgeries done in your tummy or down below before? Do you have any family history of concern? And if you are in the oncology, please don't forget to ask about breast cancer, ovarian cancer, endometrial cancer, and bowel cancer, and ask one by one. So if it's yes, you will know yes for what. Do you have any family history of concern? No, doctor. So any family history of breast cancer? No. Ovarian cancer? No. Cancer of the womb? No. Bowel cancer? No. So now it's okay, it's done. Mental, and also it's very important for me, and here actually in UK, they are keen about the mental health of the people. So in the last 4 weeks, this mental health question, you have to ask in the antenatal care, maternal medicine. Any patient will go for a surgery because she may be affected. Post-operative complications, for sure, her mental health is compromised now. A patient with hysterectomy, and now she has fistula. So she will be under stress and she will be anxious. her mental health is compromised for sure. So just ask the 2 whole questions. In the past or in the last 4 weeks, did you feel that you are depressed, on the edge, or low, or not interested to do your usual activities? Very important question, guys. Social, what about support at home? And in some cases, we need to exclude domestic violence, like, for example, in patient with vaginismus, chronic pelvic pain, patient with recurrent visits while she's pregnant with bruises or reduced fetal movement, okay? Because she has like a fall or anything like that. So please exclude domestic violence after giving one signpost. One more point here, like the sexual history, it's not mentioned because this is general for everything. Sexual, it's for specific modules. So we need to give one signpost before the sexual history, guys. I will touch this point. It's not written, but I want to highlight it also. So you will give one signpost. You will say, I'm so sorry, I want to ask you some personal questions. I know it's a little bit intrusive, but it's very important in our management. Shall I proceed? Yes, doctor. So are you sexually active? So start step by step. Don't tell, do you have multiple sexual partners? No. Start question by question. So are you sexually active? Yes, doctor. Are you in a stable relationship? Yes, doctor. So once she's in a stable one, so no multiple partners here. Did you have any history, or do you have any history of sexually shared infection? No, doctor. And for your partner? No, doctor. So this is the way how you're going to ask. This is very important in the communication also with the patient, how you will give the signpost. It's personal question, but you are asking the patient permission to start to ask this point because it will be very important in the management. Then finish your information gathering by saying, thank you for sharing this information with me. Do you want to add anything? Sometimes you may forget one point, and because you are a very good candidate, the role player will be a very good role player, and she will tell you, yes, doctor, one more point I want to add, like this. She will tell you one point. And usually this is my advice. If you are a good candidate, you will find the role player. She's very cooperative, and she will tell you, doctor, please, for example, I'll give you example just to know. So for the vaginismus, you forgot to comment on the surgery. So you will find the role player by the end. She will ask you, doctor, please, is there any rule of surgery in my management? So this is a very good role player. She's helping you at this time, by the way. And take care that every question from the role player is a mark. So take care of that because she has a script. So in the script, it's written, if the candidate doesn't ask you about this point, ask him about that. If the candidate mentioned this, ask him about that point, and so on. So she has a script. So it's not from her mind. It's RCOG question. So it's a mark. Okay. Then examination. Before proceeding to examination, guys, do you have any questions for anyone? Just unmute yourself and speak.
It's clear, ma'am.
Okay, thank you, Shasista. Thank you. Okay, so examination, and this is now we have 2 opinions, as I mentioned, but if you want to examine the patient, here I put 2 sentences, one for the face-to-face, one for the online. But now this sentence will not be used anymore unless the RCOG will take again another decision to make the online back again. So you will tell the patient, I would like to offer you examination in presence of chaperone after your permission. Usually, guys, and this is my advice, some of you, and it's correct, it's not wrong to tell, I'd like to examine you, or I want to examine you. Yes, it's correct, but it's a little bit unpolite. Why? Because here the patient has all the rights to agree or to refuse. She will say, no, I don't want examination. Okay, all respected. I respect your wishes. So offer, the word offer in English means you have to accept or to refuse. You can agree or not. So it's all your decision by the end, and I will support you. So all these meanings in one word, offer. I would like to offer you examination. Like admission, I'd like to offer you admission. Don't say, I want to admit you. Yes, it's correct. But if you will say offer you admission, it's better, good communication, or better communication with the patient. Okay, guys? So I'd like to offer you examination in presence of chaperone after your permission. Is it okay? Okay, doctor. For the online, since this is an online consultation, so when I will face you or when I will meet you, I'd like to offer you examination in presence of chaperone after your permission. If you will say this sentence for the face-to-face, just pause for 1 or 2 seconds, 1, 2, then say, thank you for your time. Coming now to your concern. So now you are ready, you have the information, you have everything regarding the patient and the notes, and you have the examination. Now you are ready to discuss the patient concerns. In the concerns, we have 2 things. Explanation of the condition. This is in all stations, and breaking bad news in some stations. And it's all counseling of the patient. It's 2 points together. So if we have breaking bad news, don't tell the patient the bad news directly. So we will use a technique, first signpost and second signpost. For the first signpost, you will say, I can see that you are here today alone. Do you want someone to be with you? No, doctor, please go ahead. So give the second signpost immediately. Oh, I'm so sorry. I think I don't have a good news for you. Don't say I have a bad news. It's not good. Okay? So say I don't have a good news for you. I'm so sorry. I have here, for example, I have here your reports after confirmation of your name, age, and NHS number. And I believe this report belongs to you. I'm so sorry. The report's showing that you have a cancer. Like this. You have a cancer in your womb. You have ovarian cancer. You have whatever. So don't say I don't have a good news for you. This report showing some abnormal cells which can be, don't explain. Give the bad after, immediately after the signpost, give the bad news like this. Okay? Don't explain and stop, or after giving the bad news, say, I'm so sorry about that, and stop. Leave the patient to absorb. Some of you guys will give the first signpost and they will not give the second. Giving the second, not giving the first. Some of you will give first, second, and then start to say, and you know this cancer because of 1, 2, 3, and we have risk factors like this, and your management will be, without giving the patient time to absorb what happened. Okay, so guys, please give the patient like few seconds. Sometimes, especially for the in the face-to-face, the patient will start to cry. Stop. It's a mark. You know, you're silent. While you are silent, you will gain marks now. But if you will speak, you will lose marks. Why? Because leave the patient. Once the patient will stop crying, for example, or make like eye contact with you, or say, okay, doctor, so what you will do for me now? So now it's a permission from the patient to speak. So you will ask her, are you okay now? Do you want me to postpone this consultation to another time? And show empathy. Don't go monotonous in the old station with the same volume of your voice. Okay? No, go up and down, especially with the bad news. Make it a little bit lower. It's a very bad news for the patient to have a cancer. So please show sympathy with the patient and empathy with the patient. Okay? So just give the patient the bad news, give signpost, give the bad news, stop. Leave her to absorb the shock. You can offer her water and tissue. I don't know, it's available now in the face-to-face. In the past, it was like this. And ask her to postpone the consultation if she wants that. And because we are in the exam, she will say, no, doctor, please go ahead. What you will do for me now? Okay? Or what is the meaning of that? So you will start to explain the bad condition she had, like a cancer. What about this cancer? What about the risk? And so on. Okay? If we don't have a bad news, it will be explanation of the condition as usual. And I put here one slide from the postpartum complications. It's the mastitis. So start to give the patient some information about it. It's, you know, this mastitis, it's inflammation of the tissue inside your breast. What happened that if we have poor milk drainage, due to that your baby not being well attached to the breast or has any difficulty in feeding. So poor milk drainage will lead to accumulation of the milk, and some bugs may start to come inside your breast from the baby's mouth or from the skin all over the breast, and it will lead to inflammation of your breast. Am I clear so far? Yes, doctor. You can use this from the patient information leaflet. That's why I'm telling patient information leaflet, it's crucial for this exam. It's very important, okay? So you can tell her that the area around the blockage will start to be red and sore. So now you are telling her what happened and what about the result, and you have this result now, okay? And usually, or some of the mothers will have also a high temperature, okay? This is the explanation, very easy. In each condition, you have to have one explanation like this to tell the patient, to counsel the patient. Then this is another slide. So I'm giving you here different examples, example of breaking bad news, example of as usual explanation. And here, if we are in the antenatal care or maternal medicine, usually in the maternal medicine, the patient knows her condition more than you in the maternal medicine. Why? Patient is diabetic since she was 7 years. What do you think? She knows everything about diabetes. What she wants to know now, she wants to know effects of the disease on the pregnancy, on the mother, on the baby, effects of the pregnancy on the disease. You got my point? So what's new now for her? The pregnancy. So she wants to know the effects now. If the patient has a scan like Down syndrome screening, this is a screening, or a scan showing talipes, scan showing echogenic bowel, yeah, now you have to explain the condition, then mention the effects on the pregnancy, effects on the disease. You got my point? For example, for the Down, you will explain the Down, and then what about the effects on the mother? It will be nothing except maybe a miscarriage if it's early, so maybe a miscarriage. For sure, the mental problems or the psychological problems, she will need support. Effects on the baby, you will tell all the effects on the baby from the Down, like physical, mental, and congenital. Okay? Physical, mental, and physical, because they have like physical changes. Mental disabilities, and educational disabilities. For congenital, it's a hole in the heart. So you can just make it like this for the Down, for example. Okay, so this is how this is slide for the maternal medicine and antenatal care. If maternal medicine, a disease, so you will go directly to the effects immediately. If you have any condition, new condition for the patient, so she doesn't know anything about the condition, so mention the condition, explain it, and then tell the effects on the mother, on the baby, on the disease. And usually here you will find, for example, Down, there is no effect on the disease. Or talipes, no effect on the disease. So usually you will tell effects on the mother, effects on the baby. Okay. Then after explanation, we will go to the management plan. And it's different in every station. And as I mentioned, please just be sure that you are go in a systematic way. So you will not forget, as Dr. Namat mentioned at the start of the presentation, you will not miss any point because now you are in a very systematic way. For example, I will give you here one example. I want a free here. So for example, the management of ectopic. Okay. Yeah, and I want also, guys, to highlight one point here because we will discuss the ectopic. So I will highlight one more point here. How you will work smart in the applied clinical knowledge. You will tell me it's a huge information and it's a huge knowledge. How I can manage that? So I will give you example of ectopic. Okay. You can cover around 200 recalls. But actually, if you will go back to the scenarios, we have different scenarios, but it may be the same condition. So you will have around 120 cases. What I mean, that for example, ectopic, we have 4 scenarios in the exam. Maybe first time ectopic, maybe recurrent ectopic, correct? This is the recalls. And for the first time ectopic, sometimes he will give you criteria that the medical management is suitable. Sometimes no, it's only surgical. For the recurrent, it's the same. Sometimes medical is the suitable, sometimes the surgical. So it's only ectopic now. How many scenarios do we have in the exam? 4. So in the applied clinical knowledge, when you will write or highlight or just make your summary, your own summary for the ectopic, what you will do, or if you will study from the material, the model answers here, what you will do, you will study management of the ectopic as a whole. So you know that we have 3 steps. Okay, so I will erase this. Do you want this slide anymore, guys? Because I want to erase this.
Yeah, you can erase it.
Okay, thank you so much. So how are we gonna manage the ectopic? So when you will write, or if you will follow the model answers here, so you will know that it's conservative, medical, surgical. Now you are saving your time. You are working smart. You are not studying the case. You know what Dr. Vanita mentioned at the start? She mentioned that in May, there were many twisted stations. During the course, what I mentioned usually, and this is my advice to all my candidates, don't memorize the station by heart like this, because now they are making changes. Be ready for any twisting stations. So if we are studying the post-operative complications, we covered, for example, the urinary bladder, ureter, blood, and for the bowel, I touched the point of bowel. I told them if we have any other injury, what you will do, don't be panic. You will follow the template, ask questions, and then coming to the bowel, make the emergency management, and then involve GIT, surgeon with you. This is the answer, because you will not fix any bowel injury, but you are managing the patient and incident report, risk management team, involve a counselor, because we have a complication now. This patient will stay for hospital for long time, so we need to give her low molecular weight heparin, assess the risk for VTE. This is the template. Now, if this is what happened exactly in the exam, they faced the bowel injury and they were following the template. They are not in panic, because while we are studying and doing the preparation, we are applying some changes, and I'm telling them if we have any changes, don't worry about it. Just follow the template. You will get around, if this station out of 8 marks, you will get 7 out of 8 by following the template. Sometimes I'm telling them, if you don't know anything about the case, you will get around 5 to 6 marks out of 8, because you are following the template. You got my point, guys? So this is how you're gonna work smart. Now we have ectopic. So don't memorize only the surgery, and don't start with the surgery, please. Even we have a scan, and the sac size, for example, more than 3.5 centimeter. It means that conservative not suitable, medical not suitable. So you will say, now regarding your management will be with a group of expert team. This will include my consultant, a specialized nurse, sleeping doctor, and a counselor, just to help you how to cope with your condition. Am I clear so far? Yes, doctor. So we do have 3 options for you. First option is the conservative, but I'm so sorry, it's not suitable for in your case, because now the pregnancy hormone or the size of the pregnancy is beyond the values we can apply the conservative management. I'm so sorry about that. Say I'm so sorry, because it's conservative. The conservative means that we will not do anything. So say, I'm sorry, it's not suitable for you. The second option will be the medical, which is injection of one medication. But again, I'm so sorry, it's not suitable in your condition, because now the size of the pregnancy is beyond the value. So if the sac more than 3.5, if the pregnancy hormone more than 5,000, if there is positive heart pulsations, if the patient unstable, vitally unstable, if the patient with pain, so at this time, the medical will not be important, will not be suitable. Our third option, and which is suitable for you, which is the surgery. Coming to the surgery, don't go directly to laparoscopy and, for example, salpingectomy or salpingostomy. You have to explain everything here, but in quickly, just touch and go, like we mentioned here, touch and go, touch and go. Then the surgical. Coming to the surgery. So we have 2 ways for the surgery, either through the keyhole surgery or to open up your tummy. Usually we are following the keyhole, or we are using the keyhole surgery. I will tell you in the recurrent, okay? This is a recurrent ectopic with unilateral salpingectomy. So salpingectomy done already in one side. So she had like one tube removed. So you will say during the keyhole surgery, it will be the decision of the consultant. Okay, it will depend on your tube and also the scar tissue around it. So the consultant will see if the tube is healthy and no scar tissue around it, and it's not burst or ruptured, no blood inside your lower tummy. At this time, we can open up the tube, taking the pregnancy tissue outside, just leave the tube open to heal by itself, or just to put tiny stitches to close the tube. Am I clear so far? Yes, doctor. But it's a surgery like any surgery. So take care of what? Complication, guys. I have one sentence you can use in any station with the surgery, and you can add one more specific complication after that. So what about the general complications? It will be, it's like we mentioned, surgery like any surgery carries risks for you, like infection, bruises, bleeding, injury of any organ inside your tummy or lower tummy. And here is specific for the recurrent ectopic, and you will do salpingostomy or salpingotomy. We have two names. You can pronounce like this or that. Another specific complication will be ectopic again, or need another surgery, or need injection, the medication. And it will need follow-up with the pregnancy hormone. So we mentioned the line, general line of complication, general plus specific. And you can use this in any surgery. If you don't have a specific complication, don't mention anything. Just mention the line of general complications. Injury, bruises, infection, okay? Injury, you can mention injury of any organ inside your tummy or lower tummy. You can mention like the water bag, water tube, bowel, or anything, okay? You can mention also the need of blood transfusion and anesthesia or sleeping medications complications also. You can add this, okay? So coming back to the management of recurrent. So we mentioned the salpingostomy. Okay, guys? You have to ask the patient, am I clear so far? Yes, doctor. So coming to the second option, which we named salpingectomy, and you have it before in your, for example, left tube. So what happened that during the surgery, if we find the tube unhealthy, ruptured or burst, there is a lot of blood or bleeding inside your lower tummy, a lot of scar tissue around it. So if we will keep the tube in place or leave the tube in place, it will be a site of ectopic again and again, and it will make your life in danger. I'm so sorry about that. So at this time, it will be the consultant decision to remove the tube with the pregnancy inside it. It carries also the same risks like injury, bleeding, infection, bruises, but we don't need to follow up this after the removal of the tube. You can just offer the patient a urine pregnancy test after 3 weeks or not, because now you remove the whole, but it's better to offer the urine pregnancy after 3 weeks. There is no need for a second, not second injection here. It will be like to give medication in the form of injection. You got my point, guys? So you will tell the patient the option, justify your answer, and giving her the complication. So while you are preparing ectopic, you will not study only the scenario of recurrent and she will use or she will need salpingectomy. No, you will go through the conservative, medical, and then surgical. Okay, guys? So you got my point, how you're gonna manage the patient and how you're gonna work smart at the start of your preparation to make it easy for you in the revision, and also you will make it easy for you in the exam. Is it clear, guys?
Yes, doctor.
Thank you, Reka. Do you have any questions?
No, clear so far.
Okay, thank you so much. So now coming to the ending of the station, what you will do, you will give the patient information leaflet. So you will say, I know that I gave you a lot of information. So
Dr.
I want
Anna, if we, because in the end the time finishes and we not reached up to the patient information leaflet, should we give the patient information leaflet in the agenda or after explaining the condition? Because sometimes we finish the time and did not give the information leaflet because it will cut the marks.
Yes, exactly.
So what should we do?
Yes, for sure, Reka. And it's my advice actually for anyone. Usually while I'm doing the preparation with the candidates, if I notice that one candidate, usually she will not be able to finish on time, I'm saying, so please put this at the start of the management. So you will say, for example, now coming to your management, but before that, by the end of our consultation, I will give you the written information regarding what we will discuss now. And I will set another appointment with my consultant. I will attach you to support group. I will write back to your GP. Am I clear so far? Yes, doctor. So coming to your management and then start the management. And now you will get here, you will get the marks.
So you mean to say after explaining the condition, we will give her information leaflet, then we discuss the management. Yeah, that's a good thing.
Exactly. Yeah.
Thank you,
Usually,
doctor.
you're welcome, Rika. So this is usually my advice for anyone will not be able to finish on time. So the communication with the patient will not be affected, because giving her the written information why is very important to hear. What happened in the clinic while we are sitting and counseling the patient, we have a nurse with us, assistant in the clinic. Just when you will tell, for example, we are discussing, for example, Down syndrome. So now Down is this and that, and you will find the assistant or the nurse giving the patient immediately while you are speaking to the patient. You know, it's very, very important to hear. Sometimes you will go inside the clinic, you will find common patient information leaflets in the print form, and it's on like a rack, so the patient can take whatever she wants for a common things like cervical screening, breast examination, like this, because it's very important to hear. So sometimes it's on the rack outside in the waiting area for the patient, so the patient can take this patient information leaflet to know more about the cervical screening, to be aware of that, and you will gain the benefit that this patient will be adherent to her cervical screening. You got it? So it's very important. It's important point in the communication with the patient. That's why you have to give by the end of the station, if you can manage the time, or immediately after the explanation of the condition. Okay, thank you, Reka.
And Dr. Anna, one more thing, in the preconception counseling, these stations are very long. In that situation, what you will advise it, like in the delivery, just we mention the timings, or should we say everything like the delivery 1-to-1 care, everything should be, because the time did not matches, because preconception counseling is very big station. So what should be?
So you will tell the patient, now we will aim, for example, diabetic patient, you mentioned this point on the group, correct?
No, in the doctor, I make the audio regarding preconception. I explain an antenatal, then postpartum. But Dr. Hamna gave me feedback that this is not a sequence. You will explain her antenatal and postpartum and then preconception. So I was confused about this. So that's why I post in the group. So what should I do? Because always when the patient come in the preconception counseling, we always explain her the preconception. Then we go to the antenatal, because men. Problem is her preconception.
Yeah, I got your point. So, you know, it's like different ways, but I like to start with the preconceptional. Why? Because now this patient, she's not pregnant.
Not pregnant.
And yeah, I appreciate that you are here today to discuss your pregnancy plan or to plan your pregnancy. So at the start, do appreciate the patient effort, and she's here today to discuss her condition with the pregnancy. She's not pregnant yet. So start with the preconceptional. I like this way. Maybe Dr. Hamna, she likes another way. All the respect, and I do appreciate her effort, but for me, I like to start with the preconception and then antenatal, go systematic. Now we are in the preconception. This is the main point here. So you will counsel the patient regarding the blood sugar control now, hemoglobin A1C. If she's on any other medications, you have to explore. You will give her high dose folic acid. And then taking her to her pregnancy journey, you will tell antenatal care and take the patient in for all the points. So you will mention that the patient will be under the consultant care. And usually my advice in the antenatal care or maternal medicine, take the patient from the gestational age she's in now. So if the patient in for example, 6 weeks, so we will start with the booking investigations and the ultrasound scan, the dating scan, and then we will discuss the Down syndrome screening between 11 to 13 plus 6, and then we will discuss the anomaly scan between 18 to 20 plus 6, okay? And then we will take the patient to if the patient not diabetic, so we will screen diabetes between 24 to 26. If there is any risk for small for gestational age at this time, so you will tell the patient that we will start to follow the patient, the baby's growth between 26 to 28 weeks, the growth scan, and it will be like frequent. And then we will discuss the delivery between 34 to 36 weeks, okay? Even we can discuss the delivery earlier. So coming to your point, for the intrapartum, we have a template. I can show you the template after we finish. I will mention here, and I will show you in the diabetes case especially. So
Thank
for
you,
the you're welcome, my dear. For the intrapartum care, we need to tell the patient that if she's diabetic, so she will be under the consultant care. She will be in the consultant-led care unit, and she will have one-to-one support. And we will aim for the timing of the delivery will be between 37 to
38 plus 6.
Because she's type 1 diabetes, this patient, or type 2 is gestational. No, we can wait until 41 weeks.
41 plus.
Yeah, exactly. Then intrapartum, what we will do also, this patient will have continuous monitoring, CTG. Any patient with medical problem, CTG continuous for the baby. She will have.
Doctor, I mean to say that in the preconception we don't get enough time. So all these things we should say, like the continuous CTG one, because the time is not enough there. In the antenatal patient, should we say all these things? But in the intrapartum, patient for the preconception counseling, should we say all these things? My point is that.
It's better, Rika. You will make it in one line, so we will not stop. I will tell you. So now coming to your delivery time, we will aim to have normal vaginal delivery between 37 to 38 weeks plus 6 days. Your delivery will be under the consultant care. You will have one-to-one support at this time with close monitoring of your condition, especially for your blood sugar level, and your baby will have a continuous monitoring with belt around your tummy. Full stop.
Full stop. Okay.
Just make it one sentence. If you will count for me, it's like 30 seconds.
Okay, we just not mention the timings of the glucose monitoring we are doing. Just we say that we close monitor your baby and the glucose. Okay.
Yes, blood sugar level. If you want to add, if you have time, you can mention it. It has to be done every 30 minutes, every 60 minutes, 1 hour without general anesthesia, with every 30 minutes with general anesthesia. So if we will take this patient to cesarean section, we have to keep monitoring of her blood sugar level every 30 minutes. If you want to add, okay? If not, just tell her close monitoring. For her condition, close or continuous monitoring of the baby by CTG.
Okay.
You got that point?
I got your point, yeah. Thank you, doctor.
Yeah. You're welcome, Rika. So now this is the finish of the template. Do you want a break, guys? We have just a few slides regarding the material. I will show you. Just a few slides, so we can continue?
Yeah, doctor, continue.
Okay. So this is the material, because some people asked me about how we're gonna go through the course. So this is example from May preparatory course. So you will find it's easy access. I'm putting everything in place so it will be easy for you. If you want one patient information leaflet, one guideline, you can go to that easily. So for example, here, urogyney teaching, so you will find all the modules like this, one after another. And then if you want to see, for example, subfertility, so you will find inside the subfertility TOG articles separately, templates, like ready templates to use, but usually I'm advised don't use the ready templates, use your template or the material from here, the model answer, like this presentation, okay? Patient information leaflet if you want to go through, and guidelines. So if I want to see the nice guideline regarding subfertility, you will find it here. If I want to check male subfertility TOG article, you'll find it here. If you want to read the patient information leaflets regarding tubal sterilization or reversal of sterilization, you will find it here in the patient information leaflet. So it's very easy. And after we will done with the module, you will find the model answer, the PDF of the presentation, of the session ready for you, and also the recording or recordings. It will depend. It's one session or two sessions. Okay, guys. So this is regarding the material. It's easy access material for everyone. Another section is the revision. By the end, we have 13 sessions covering 13 modules. By the end, you will find the revision. And we have 8 revision, and actually for November now it will be 9, because we will include the new stations in May. So it's even more than one session for the new cases. So you will find also in the revision, the recording and the PDF. It's in all these revision, it's covering the recent recalls plus what missed in the modules, because usually in every session we are covering 7 stations. So in some modules, as I told you, for example, antenatal maternal medicine, you will find 28 cases. So I'm giving 2 sessions, so it's 14. The remaining 14 will be covered here. Each revision will contain different and mixed modules. Why? Because the revision will be done like 2 months before the exam. So now my candidates will be ready to go from one module to another easily. I'm not giving here, for example, antenatal only, here maternal only, here early pregnancy. No, it's mixed. Okay? And what happened with May exam, I was giving them 2 opinions. I told them we can go with the revision like this, the normal sessions, like every candidate will do 1 station. Or we can take, for example, Dr. Vanita will take revision 1, Dr. Namat will take revision 2. So it will be like 3 mini mock by the end of the course for the candidates. So you will go with 7 stations, different modules, back to back, and then to get the feedback by the end. So it was of great beneficial for the candidates at this time. You can find also like here partogram and CTG also, but it was down. So we have some recent updates for the CTG and partogram. So it was like a separate sessions for them at this time. So this is how you're gonna go through the materials. And then patient information leaflets. This is the last part of our discussion. It's very important, guys. That's why I'm putting it in the presentation by itself. How you will read the patient information leaflet, how to gain the information from it. I'm usually telling my candidates, you will find all the information in the model answer. You can follow the model answer. But my advice, just take 1 case daily. Read the patient information leaflet of this case, because you will learn the layman language. You will learn the good explanation. You will know more about the questions maybe asked from the role player. So how are we gonna read it? I'm putting here 1 example. It's the molar pregnancy, and it was published from the RCOG. Even it's updated with the guideline, guys, because the guideline updated in 2020, if you remember. So the patient information leaflet also, it's updated or published in 2020. So molar pregnancy, what we want to know, just highlight, actually this is my highlighting, okay? So just highlight the important points. It's a rare condition, okay? When a pregnancy does not develop normally from the very beginning. You can use this word with the patient or this sentence. So this molar pregnancy, it's a very rare condition, or it's a rare condition where the pregnancy doesn't develop normally from the early beginning. It means from the fertilization. Okay, very nice sentence, and you can use while counseling the patient. Then continue. We have key points. Very important to go through the key points, because this is what you need to know by the end of the patient information leaflet. It's uncommon group of condition or rare, cannot develop into a healthy baby, because maybe it's a question from the patient, especially in the partial mole. She will say, okay, so it can develop into a baby. You will say, I'm so sorry, it cannot develop into a healthy baby. Okay, we may use small operation to remove abnormal tissue from inside your womb. Okay, may persist after surgery, and we need to refer to a specialist center, which is the GTD center. So this is how you will get or pick the important information from this patient information leaflet. What is GTD? Very important point. This is the counseling. This is how you're going to explain the molar for the patient. Pregnancy does not develop normally from the early beginning. Okay? What happened? You can just touch the point that you can mention this, and one of the examiners one time, he told me, don't mention that. Don't mention one sperm or two sperms with the empty ovum and these things. Just tell it's abnormal, and I'm following his advice actually. So it's abnormal growth of the pregnancy from the early beginning. It's abnormality of the afterbirth. Okay, so it's abnormality in the afterbirth. If you want to discuss more about the sperm and empty ovum, no problem. But it was one of the examiners when I attended the course of the college one time. So he advised me, don't tell the sperm and ovum and these things. So I'm following his advice. Complete molar pregnancy. This is explanation you may keep for your knowledge. It will not be very important for the patient to know that, as I told you, single sperm fertilize empty egg or double up to give the pregnancy after that. Okay, so if you want to mention, as I told you, it's up to you guys. Here, explanation of the partial. Come to the important point. What might a molar pregnancy be suspected? Or sorry, when? So this is for your information, just to know if the patient will be with irregular bleeding, even after miscarriage, even after delivery. So keep in mind the molar pregnancy, it will be at this time GTN, okay? So very important when to suspect a molar pregnancy. So just highlight when to suspect as I did here, okay guys? Then what follow-up will I have? So you will see the follow-up of this patient. We have 3 centers, specialist centers, one in London, one in Sheffield, one in Dundee. So you can mention this to the patient, or just you will say, I would like to involve a specialist center, which is the GTD center. They will send for you a kit to your home just for your follow-up. Okay, and also it's very important because they will follow, and also for the statistical methods, just to count how many molar pregnancies and these things. Okay, this is how you're gonna take or pick the information from the patient information leaflets. Common questions from the side of the patient or from the patient side: when can I get pregnant? This is a question in the exam. And if there is any long-term problems, or even you can tell the patient, sometimes you may have a persistence of bleeding, or your pregnancy hormone level will be higher than normal. At this time, we may need to give you more medications. Okay, touch the point of the chemotherapy, touch and go, don't mention more. If you have time, you can give one side effect, which is the earlier menopause, 1 year with the single agent, 3 years with the multiple agents. Very easy. You can mention this point to the patient if you have time. Contraception, just touch the point of contraception, especially if the patient will develop GTN. So we have to wait 1 year until she will complete, after completion of her treatment. So you will wait the treatment, and then 1 year after, and then allow the patient to be pregnant and to be scanned early in pregnancy. Any patient with molar pregnancy or ectopic pregnancy, so next pregnancy, she will have earlier scan just to diagnose if this patient will have this condition again, because for sure for the ectopic, for the molar, there is a high risk of recurrence. If the patient will have one ectopic, then she will have the second. The risk will be more and more once she will have 1, 2 ectopic, 3 ectopics. Okay, and for sure it's the same for the molar pregnancy. So this is how you're gonna go through the patient information leaflets, guys. It's only one case daily to do. It's very easy. This exam, yes, it seems hard, but if you will work smart, as I told you, now I told you how you will do smart or work smart in the information gathering with the template, and also to remind the explanation in very easy way. Take care that the easy way is patient communication point, because now you make it simple for the patient to understand. And how you will be smart in doing the applied clinical knowledge, how you will go smart with the patient information leaflets. Okay, guys? So this is the end of our session today. I wish it's a good session for you. If you want to ask anything, I'm more than happy to answer any question. Okay, any questions, guys?
No, doctor.
I assume it's clear.
Yeah.
Okay, thank you so much for your attendance.
Thank you, ma'am.
The recording will be there, so I will post it on the group, the case discussion.
Thank you, doctor.
You're welcome, my dear Shazia. Thank you, my dear Rika. Thank you, all of you, for attendance, and many thanks for Vanita and for Nemat, because they shared their experience. If anyone doesn't attend from the start, so the recording will be there. You can hear to their advice regarding how you're gonna manage your time and study. And it's very easy, inshallah. It seems hard, but with working smart, just remember my advice. With working smart, it will be very easy, and you will pass this exam with a very high mark, inshallah. Thank you so much, Dr. Sara.
Thank you so much.
Thank you so much, Dr. Khurshid. I don't know who speak in just a few seconds. Rika or Nasreen? Okay, thank you. Thank you so much, guys. So we will stop here. Inshallah, I will arrange another free sessions, and it will be for the new stations, like the HRT with the malignancy, with the gynae malignancy, and also the bowel injury. I will discuss, inshallah. I will announce on the group. Thank you so much, Dr. Khurshid. Thank you so much, Dr. Bhakti. I don't know I'm pronouncing good or not. Sorry for that. Okay, guys. Thank you so much. Assalamu alaikum wa rahmatullah.